Think we are live. Hello, everyone. This is the next episode of TWIG. TWIG stands for This Week in Global Health. Today is September the 10th, 2014, and today is World Suicide Prevention Day. And so our episode today is really going to focus on mental health in the global health space. Before we carry on, I'm going to ask the panel members to introduce themselves. We're going to start with Emily. Emily, can you talk to us about who you are and what are you going to tell us about in this week's episode?
Sure. Well, hi, I'm Emily Lencinello, and I'm here from Toronto, Canada, and I work at Center for Addiction and Mental Health. And today I'm going to be talking about barriers to mental health care, specifically stigma, and also screening and assessment tools that should be culturally adapted.
Okay, thanks, Emily. Next up, Christy. Christy, who are you, where are you, and what are you going to talk to us about today?
I am Chris Ronson. I'm coming to you from San Francisco, California, and I'm going to be reviewing some RFPs as well as job opportunities related to our topic today.
Thanks, Christy. Okay, next up, Jessica. Jessica, talk to us.
Hey everybody, I'm Jessica Taff, and I'm coming to you from the Washington, D.C. metro area, and today I'm going to tell you a little bit about global mental health research, the challenges, some of the main issues, and also what some of the key priorities in it.
Okay, and of course, not last but not least, we've got Natasha. Natasha, talk to us. Who are you, where are you, and what are you going to tell us about today?
Hi everyone, I'm Natasha Matthews, a student from the UK, currently based for the summer in Geneva at the WHO Department of Mental Health and Substance Abuse. I'm going to be talking to you today about the Mental Health Gap Action Programme Forum that happened last week.
Okay, now, as all of these lovely people give you this interesting information, they're going to be making reference to web pages and places on the internet, etc., etc. And you might be thinking, how do I get information about where these web pages are? How do I get the links, the URLs? Not to worry, nobody panic. We send out a weekly newsletter. It's the show notes after each show. And if you want to receive that newsletter, if you want to get those show notes, then you can subscribe to this newsletter. How do you do that? Well, in the description on the event page where you're watching this, we'll have a link as to where you can subscribe. The other place that you're going to be able to find that link is in the description underneath the video on YouTube. So just to put you in the picture, this is going out live. We've got people watching this live, but this entire show will also be archived on YouTube, and a lot of people will be watching this on YouTube at some point in the future. So if you look in the description below this video, you're going to see a link. Click on that link. It'll take you to a form. You can subscribe, and we're going to send you the show notes. That'll have all the links, etc., etc. We're also going to try and include all of those links, etc., etc., of course, in that description below the YouTube video as well. But if you want to get a weekly thing, that's great. The weekly newsletter will also tell you about where the time, etc., etc., for the next episode. Okay, enough about that. Let me just tell you one or two more things that you can communicate with us right now, but with the hashtag TWIG, TWIGH. That stands for This Week in Global Health. Right, so on Twitter, you can send us a question. You can also send us a question on Google+, and on YouTube, of course. We're going to deal with most of the questions probably at the end of the show, but if something interesting pops up while we're talking, we'll try and address that. You can also email us. So you can email us at thisweekinglobalhealth@gmail.com. Now, why might you want to email us? Email us if you've got suggestions about content, like you might say, look, we'd like to see a show on X, Y, and Z, or you'd like us to profile an organization. Maybe you work for an organization and you'd like that organization to be profiled on the show. Get in touch with us. Maybe you've got a great idea. You've got some intervention and you want to you want to come on the show and talk about it. Let us know. Get in touch. Email us. Twitter us, do whatever you can, get in touch. This is supposed to be interactive. This is the internet. Okay, we're going to jump right in with a couple of news items, actually research items from Jessica. Right, Jessica, talk to us.
Sure. So yeah, I was going to tell you a little bit about global mental health research. So in general, this is a neglected area of the global health research world if you compare it to things like infectious diseases or chronic killers such as cardiovascular disease or cancer in the developed world. This is a big issue, and one of the big issues is that 90% of randomized control intervention studies for mental health interventions in children are done in high-income countries, even though 90% of the world's children live in low- and middle-income countries. Now, this is a great disparity in where mental health research has been carried out, and this has been pointed out by the WHO in their Global Mental Health Action Plan. And this is a report, they highly stress how mental health research really needs to be carried out in countries themselves to better address those unique needs, and it has to be done in diverse populations. And the other thing about that is, in order for them to be able to carry out these studies, we need to be helping them build research capacity as well.
Right, Jessica, I have a question for you. What do you believe are the research priorities in the mental health space right now today?
Sure, no, and I'm glad you asked that. So there was a great article in Nature in 2011 that identified a lot of these, but some of them are, one, identifying what are the biological, the sociological, the environmental risk factors, the causes, but also protective factors that are associated with mental health disorders. Another one is looking at what are effective interventions for reducing stigma that associate with mental health disorders. And then another key question is trying to assess whether health lay workers are able to provide effective care for mental health disorders.
Okay.
And so if anyone wants any background on this, you could go to the show notes. There's plenty of information on mental health research there, and also a recent article that came out in PLOS looking at the costs of working through depression.
Okay, so the links to all of those will be in the show notes. Next up, we're going to ask Emily. Emily's going to talk to us about culturally appropriate tools that are used in the treatment of mental health.
Yes, thanks, Greg. So one of the things we think about when we think of mental health is, of course, assessing and diagnosing people with mental health problems. Now, typically, whenever a psychiatrist or any other kind of doctor assesses or screens somebody for a mental health problem, they use tools or measurements. So these are usually whether they're questionnaires or things like that to measure somebody or measure whether or not they have a mental health problem. One of the issues, though, is that the vast majority, I would say well over 90%, of tools and measurements for diagnosing and screening were developed in high-income countries, specifically North America and parts of Europe. The issue with that is that these tools were not only developed but also developed by and validated with very specific populations, namely Caucasian and African American populations. So when you're looking at sort of questionnaires or measurements, screening measurements, that were only developed and validated in one part of the world, it's really not appropriate necessarily to think that these tools and measurements will be appropriate in all parts of the world. Some of the questions that these tools may ask may be inappropriate or offensive or have a completely different meaning in other parts of the world. So some people have tried to take steps forward by doing things such as translating questionnaires into different languages, and that's a nice start, and sometimes that's all you need to do if it's pretty basic and simple. But most people are finding that you actually need to take extra steps in culturally adapting questionnaires or measurements and tools, so it goes beyond just doing a different language. Not just questionnaires and tools, but also actual treatment methods. So a very common, well-known treatment method is called cognitive behavioral therapy, or CBT, and this is a treatment method used extensively, certainly in North America and Europe. And one of the things that we've done here in Canada is culturally adapted CBT through a very long process. It's culturally adapted it for the Creole and French-speaking population here in Canada. And that's actually currently also being tested in Haiti to ensure that the tool itself is appropriate and it works. So there is lots to think about when thinking about measurements and tools, and that there's more to culturally adapting them than just translation.
Right. Very interesting. And in actual fact, I've had a little bit of experience along those lines myself, in that I worked in the Department of Psychiatry at Chris Hani Baragwanath Hospital in Soweto in South Africa. Mm-hmm. And something I noticed was that a lot of the patients would interpret their symptoms in the context of their culture. So if they had schizophrenia and they were having auditory hallucinations, very often they would interpret those hallucinations as perhaps the voices of their ancestors speaking to them, or something like that. So, not just the tools, but the actual way in which clinicians and the medical staff engage with patients needs to be culturally sensitive.
Well, and just a side note too is when we think about that, we're using manuals such as the DSM, which is the Diagnostic and Statistical Manual, and the ICD, and these are the two kind of Bibles of psychiatry and diagnosis, and both were developed in high-income countries.
Right, in the States and the UK respectively. Yeah, absolutely. Okay, a couple of quick little factoids about mental health that you may or may not have known. About 20% of the world's children and adolescents suffer from mental disorders or problems of some kind, and that's according to the World Health Organization. Depression is the leading cause of disability worldwide, and it's a major contributor to the global burden of disease. Rates of mental illness tend to double in emergencies. Okay, and so that's quite important. When we see emergencies or conflicts, we often think about all of the trauma and the physical ailments that go with it, and of course those are important. We often forget about the fact that mental health is also a huge consequence of those sorts of emergency situations.
And just to step in, Greg, if I may. Is when we're also talking about emergency situations, whether it's an emergency such as war or natural disasters, is a lot of the mental health problems that we see are acute. So of course something bad happens and immediately mental illness may occur, whether it's severe anxiety, depression, things like that. And the key is really for these people to get treatment right away so that they don't become long-term or chronic problems. And of course a major issue in global health across the board is those resources are almost never available for people who most need it. So they do often become chronic problems when really if people sought or received the help they needed right away to deal with that, whatever the disaster may be or emergency may be, then that mental health problem would be acute and be short-termed.
Right. And I mean, just, to add to that whole resource thing, my final little factoid is that in low-income countries, there are on average 1 psychiatrist per 2 million people. That's the ratio. Now, the rate of psychiatrists in high-income countries is about 170 times that. So that just gives you a sense of, people are living in poor countries. Not only do they have to deal with all the difficulties of being poor and all of the problems associated with that, but if you have mental illness, which isn't easy anywhere in the world, your opportunities to access care are limited. And I think, I remember treating a patient that had generalized anxiety disorder. And, when I was treating this patient, I remember thinking, well, the serious mental health problems are schizophrenia and severe depression and bipolar mood disorder, and I didn't really think generalized anxiety disorder was that important. And I said to this patient, what is it like? I mean, I think people that are well find it very difficult to understand just how much people with mental illness suffer. And so I said to this patient, look, what is it like having this anxiety disorder? And she said to me, have you ever walked past a gate where you didn't know that there was a dog on the other side of the gate? You're walking past the street, you walk past a gate, and a dog suddenly jumps up and barks at you. And in that moment, you get this sudden fright, this kind of electric fear. Your whole body tenses up. And it's an awful feeling. And I said, yes, I've had that. I mean, I grew up in South Africa. There's a lot of dogs that bark in South Africa. And she said to me, that's how I wake up in the morning. I wake up with that feeling, and I feel it all day. And when she told this to me, I remember just thinking, I can't even imagine living like that. That's a whole different kind of suffering. It's something that I couldn't even begin to relate to. Right, moving right along. Emily, you're going to talk to us a little bit about barriers to access. Jump right in.
Yeah, so we certainly know there are many barriers for people to seek care everywhere in the world, and sometimes those barriers differ depending on where in the world you are, but they certainly are everywhere. As Greg mentioned a few minutes ago, some countries may only have 1 or 2 at best psychiatrists or mental health professionals in the whole country. So certainly accessing professional resources can be a significant barrier. So can things like cultural beliefs, money, even awareness of service, so knowing what to do if you're feeling like you may have a mental health problem. One of the issues, though, that we certainly see globally is stigma, and stigma is a very significant problem across the world. Stigma is essentially people, systems, communities portraying negative attitudes or even fear towards people who have mental health problems. So they creates an environment or an atmosphere for the person who's suffering to not want to seek help because they are embarrassed or they don't want to be shamed or ostracized from their families, communities, etc. So it's a significant barrier, certainly, across the world. We also see a problem with stigma in the addiction field, which of course is under the umbrella of mental health, and that we find a huge amount of people are underreporting how much substances perhaps or other addictive behaviors that they're involved in or engaged in because of stigma, because of that embarrassment or shame that they may feel either just internally or if that's put onto them from members of their community or the system at large. So stigma is certainly one of the biggest issues at the moment.
Yeah, no, I'm sure that is a big issue. Thanks very much, Emily. Next up, Natasha. Could you talk to us about, in the last 2 weeks, there's been a meeting at the World Health Organization about the mental health gaps. Tell us about that. What is the Mental Health Gaps Forum? I don't even know if I'm using the right phrase there. And what were the outcomes of that meeting?
Yes, sure. So last week was the World Health Organization's Mental Health Gap Action Program Forum, which, yes, is a bit of a mouthful. Just to give you a bit of context, the MH Gap Forum is the WHO's annual event on mental health, and it's an informal group meeting of mental health stakeholders to implement the MH Gap program. Now, Greg, you mentioned before that we have a huge problem, particularly in low-resource settings, of lack of mental health professionals to deal with the burden of disease. So the MH Gap program is the WHO's program to scale up care for mental, neurological, and substance use disorders. It upholds that with proper care, medication, and psychosocial support, millions more people can receive mental health care and begin to lead normal lives, even when you have scarce resources. So at the forum, we had the launch of the WHO's first World Suicide Report, and there'll be a link in the show notes to that report for you to take a look at. There's also a call for action from Professor Graham Thornycroft to press governments for stronger inclusion of mental health in the UN Sustainable Development Goals, and we'll have details in the show notes about how you can get more involved in that campaign.
Okay, absolutely, and I couldn't agree more that mental health needs to be included in our agenda going forwards when we talk about sustainable development.
Mm-hmm.
Mental health is very often not thought of as a priority, and yet, as we've talked about in the show, it is a significant contributor to the global burden of disease. One of the things, I'll just sort of editorialize for a second here. Mental health is typically massively underfunded. And part of the reason, in my opinion, and I don't have any kind of papers to back this up, but this is just my sense of what's going on, is funding agencies like to fund programs where there's nice, easy to measure outcomes, right? Where we're treating X people with this infectious disease and this number of them got better. And so this is what we got for our money. And we can tell our stakeholders that this is what we accomplished. Dealing with something like mental illness is much more difficult in terms of measuring the outcomes. People have these diseases for long periods of time. The extent to which they recover might be very difficult to measure. But that doesn't mean that they're not suffering, and that doesn't mean that the things that we can do to help them aren't significant. It's because I've worked in psychiatry. I'm quite passionate about this. I'll stop right there. We can talk more about this in the discussion part of the show a little bit later. But for now, just to kind of move things along, I'm going to ask Christy. Christy, could you jump in and tell us? I believe there's been some calls for requests for proposals for grants, and there's a job offer out there that you wanted to highlight.
Yes, I'm going to keep it short and sweet today. We've got one RFP that I'm going to cover for the Fogarty International Center. The project is the Global Brain and Nervous System Disorders Research Across the Lifespan, which is a really interesting program. Their research program does support collaborative research and capacity building projects relevant to low and middle income countries on brain and nervous system disorders across the lifespan of the inhabitants of those countries. Grant recipients should develop innovative collaborative research programs that contribute to the goal of building sustainable research capacity in nervous system function and nervous system impairment. And we've got two deadlines for this one. The first one is December 5th of 2014 of this year. And if your research is related to AIDS as well, or non-AIDS application due dates, those are January 5th of 2015. So just a month after this initial deadline. We also have a job opportunity. It's for Salud por Derecho. It's a policy and advocacy officer. It's a 12-month contract in Madrid. It's available as soon as possible, and the deadline is this month. Salud por Derecho is a human rights organization focused on defending the right to health through political advocacy, awareness raising, and social mobilization in Spain, the European Union, and on the global level. The organization works so that all people are able to exercise their right to health. For more information and more details about eligibility criteria and all of the things needed for applying to either of these RFPs or jobs, please see the show notes. The link is on our Google Plus page, so follow up with that.
Okay, thanks very much. Okay, so now, for those of you that are watching this on YouTube at some point in the future, this is the end of what you're going to watch, right? So I've just popped something on the screen at the moment for you to just, you know how to find us on YouTube. You can support this channel at Patreon, so we'd really appreciate any support. Of course, you can follow us on Google Plus, and I've also just highlighted some videos that you might find interesting to watch on YouTube. Okay, so this is going to end on YouTube. For those of you that have been watching on YouTube, thanks for watching. Don't ever change. Don't do drugs. We love you guys. See you next week, same time, same place. Well, actually, we won't see you anytime because you're watching on YouTube. For those of you that are watching this live, don't go away. We're going to carry on, and at this point in the show, we'll have some back and forth, some questions, and just some more discussion. Okay, thanks very much. Thanks for watching. See you next week. Take care. Bye. Okay, so that'll be the end of the show. That's on YouTube, but we can carry on talking. And at this point, if we've got Chris, have you seen any questions coming in over Twitter or on Google Plus? Oh, you're on mute.
Sorry, doing great. Let's see. We've got a lot of feedback coming in through Twitter on the mental health topic. I do have a question from Annette Collins, actually, on Google Plus. She asks, can mental health disorders be addressed preventatively or can we only react to them post-manifestation? If we can't address it through prevention efforts, what can we do?
Oh,
I realize it's a big question, but it's a really good question.
It's a great question. That's a great question. And so firstly, Annette, I assume you're watching, and we know Annette well just through, she's been very active in terms of engaging with the YouTube channel, and so hi, thanks for the question. Now, in terms of preventing mental illness, it's a tricky thing. I mean, there are some postulates around, for example, your severe mental illness. If we just put this in a little bit of context, we've got things like schizophrenia. So patients with schizophrenia present with auditory hallucinations and delusions, et cetera, et cetera. Now, we know that there is a relationship between schizophrenia and substance abuse. We don't know always whether the extent to which that's causal. So, for example, there are a lot of papers out there that talk about whether or not smoking marijuana leads to schizophrenia. Now, we know that there is an association, but we don't know that it's causal, because the thinking is that it might be the case that people that are going to develop schizophrenia actually have very early, subtle signs and symptoms of the disease, which they land up trying to self-medicate by turning to substances, or some of those subtle early signs, so before they have a florid disease that can be diagnosed, some of those early precursors of schizophrenia mean that this is the kind of person that may be predisposed to taking higher risks or behaving in a certain kind of way that might be different from. So it's very difficult to say whether or not that there's a causal relationship there or not. And I think so that's the difficulty with understanding like kind of the prevention of mental illness. We know for a fact that schizophrenia has got a genetic component. So people with schizophrenia, if they have children, we don't know, they won't necessarily definitely get schizophrenia, and we've looked at twin concordance studies, so twins who have the exact same genes, some of them will get the disease, some of them won't. So we know that it's not entirely genetic, but we know that there's a genetic component to it. So what that means is that there's a genetic component, but there must also be an environmental component, so there's an exposure element to it. So that's important to realize as well. And I think for something like depression, obviously there can be precipitants to depression. Okay, and when we talk about depression, we're not just talking about people that are having a bad day or a little bit sad. We're talking about people who are clinically depressed, who are unable to function, that they really are in a bad way. Certainly there are predisposing factors and precipitants, and we can work as a society to try and mitigate those. I think one of the important things about when treating mental illness is we want, as far as possible, to treat the people in the community. We want them to be attending an outpatient clinic instead of being treated in a hospital, being in an inpatient, in a ward, surrounded by other unwell people. That's not necessarily a healthy place for that person to be. If we can treat them in the community and we can give them, and it's a multidisciplinary treatment approach, right? So it's not just see a psychiatrist, right? It's see a psychiatrist, get on the right meds, see a psychologist, work with an occupational therapist, work with a social worker. You've got to get the whole team involved and do everything you can to make this person able to function as optimally as possible at home and in the community. I'm not sure if that entirely answers your question, but that's my sort of 2 cents worth. I don't know if anybody else on the panel has got a thought on that.
Yeah, I'd like to just say something. So. Yeah, I mean, prevention of mental health problems, of course, it depends on the mental health problem we're talking about. Of course, things like schizophrenia, bipolar disorder, things like that are very strong genetic links. So sometimes you may not be able to prevent it per se, but sometimes, and I mentioned this earlier when talking about emergencies, is one of the biggest challenges or issues isn't always preventing, but getting people at the beginning. And that's one of the biggest issues. So it's not always so much about preventing it from happening at all, because sometimes that's not possible. Sometimes it is, and I can say something briefly about that. But it's always typically more about getting people at the beginning. So as soon as somebody has a depressive episode or any kind of psychosis, whether it's seeing something or just even feeling a sense of paranoia that's not healthy, to get help right away can really eliminate all of the long-term effects that can happen. And one of the biggest problems we see, again, everywhere, is people wait, whether they wait because they're scared or they wait because there's no resources, whatever the reason may be, they're often don't seek help anyway until it's really severe, until they're almost not able to function. And that becomes the real issue, because it's much harder to get those people well enough to be able to function sort of in society, and whether it's have a job, a family, etc. So a bigger thing to me than prevention is actually helping people at the beginning. And we're talking about prevention. One of the biggest things, and I'm hoping this may actually be a topic for one of our future shows, is social determinants of health. So we're talking about education and income, just basically those things that happen to everybody. And if those things get out of kilter, especially more than one, then it can increase somebody's susceptibility to developing a mental health problem. So if you're unemployed, you have no income, maybe your family's passed away. In Toronto, or in Canada rather, we've also added to that list things like racism and discrimination, because when someone experiences several of these negative parts of the social determinants of health, the increase of mental illness increases. So it's really important we're looking at prevention, and I know Greg mentioned this a little bit in terms of things we can do as a society. People who are struggling, whether it's in poverty or whatever the case may be, those are, certainly precedents to developing a mental health problem. So eliminating some of those severe stressors can certainly eliminate many of the mental health problems we see today.
Yeah.
So I just want to pipe in, because I think this is important, because you guys, just so we don't paint this dire picture of mental health is, of course, and it deserves a lot of attention. And I think one of the reasons is because it's not paid attention as well. And we've already talked about that a lot during this show. But this is where research can come in, and this is why it's so important to make sure that, of course, we're looking forward and thinking about how are we treating these people, catching them early. But the more research that we do, the more that can help down the line. So it's also really important to put the focus on what are not just the biological or the sociological or ecological factors that go into that are associated with these mental health disorders, but also just the research that goes into identify what interventions work, how do you reduce the stigma. This is really where research can come in, and as long as you're linking the research practice into, or the research results into practice, then it paints just a more optimistic picture of where we can go with this.
Yeah,
I think that's just sort of, sorry, Greg, not to interrupt, but I think I work in research myself, so I certainly agree with you with a capital A that research is certainly important. Myself, I do social research, so I agree with you. I guess the always caveat of that is you have the research, then what do you do with it? And a huge problem we have is we can develop these amazing policies or things for the government or for system change, and then the government, they don't want it, it just dies, it never happens. And to me that's the most frustrating part, is you can do such phenomenal research, whatever it's on, whether it's prevention or intervention, but if it's not picked up, or say funding isn't extended, or a whole bunch of factors, it just sort of dissipates, or the research isn't used appropriately, and to me that is frustrating.
I can imagine.
You've got to get the getting the governments involved in it, or putting it somehow, tying it very strongly into a program or within a grant, or very translational, saying this research is directly going to be implemented or something like that. I definitely see where your frustrations are with that, Emily, but I think there are ways that we can get around that.
Yeah, and there's ways to also kind of incentivize governments to get on board. So one of the things, I'm here in Dublin, and I was recently reading the Irish Health, Healthy Ireland. It's a report that came out looking at Ireland. Now, in Ireland alone, the economic loss, in other words, the lost productivity because of mental illness, so people that are not contributing to the economy because they're unwell, amounts to about $8 billion a year, which is huge. You use a number like 8 billion in a small country like Ireland. Ireland's got 4 million people living in it, right? So it's, it's the size of Manchester, right? When you talk to policymakers in Ireland and you use a figure like $8 billion a year are being lost through lost productivity because of mental illness, that gets people's attention. Now, clearly we can't get all of that money back. We're not going to get all people that have mental illness out in the workforce being productive, blah, blah, blah. That's not going to happen. But we can, if we even made a 2% dent in $8 billion, that's a huge chunk of change, if that makes sense, right? So, and this comes back to what I was talking about earlier. We don't want people in the hospital. We want them in the community for two reasons. Firstly, if they're in the community and they're able to work and contribute and function in society, not only is that good for society, of course, but it's great for the person. It's good for their mental health. There's a self-perpetuating cycle of kind of getting out of the rut of being unemployed and at home and unwell to being out there with a job. And anyway, I'm just wondering if we should, are there any other questions that we want to jump on?
Can I just add to that, Greg, really?
Yeah, jump in. Natasha.
So I just wanted to add two things. Just that currently being at the WHO, I've personally witnessed that they're really concentrating on building the economic case for scaling up mental health care. And actually, one of the health system advisors has done some beautiful research showing clearly that investing in mental health is cost effective. And I think so. I'm seeing that in the future we might have a change about the amount that we actually invest in mental health care. The other thing, just going back to the prevention question that I wanted to talk about, was just that I really agree what's been mentioned before, that we have a lot of wonderful policies and prevention programs in place, but that they're not always implemented. And one of the things that I see as massively lacking is actually getting people early and when they're young, educating them about mental illness. So, for example, kids in school. And coming from the UK, we don't have anything about mental health in our national curriculum guidelines. And I think that's a real problem, because you're not telling people about symptoms of mental illness or anything like that, or how to access care. And that in itself means that any kind of nice policy about prevention measures isn't really going to have a huge impact, because people aren't able to actually utilize those policies.
Okay, interesting stuff. Anything more from Chris? Questions out
I
there?
just wanted to say we did get a question on Twitter from @KatieJackson, and I just wanted to say I think we covered it pretty thoroughly. She asks, what are the greatest barriers to addressing global mental health? It sounds like there's a ton of barriers out there, be they social or economic or cultural or bureaucratic. There's a little bit of something that serves as an obstacle, and there's definitely some multi-faceted approaches that we can use to start putting global mental health like at the forefront of things that need to be addressed. I did want to say, though, prior to the show, Emily was talking about some interesting facts about suicide and about mental health, and so I wanted to hear a little bit more about those if we had time in the show for discussion.
Yeah, Emily, jump right in there.
Sure.
Just about
so
it going
before the
beyond like only the cultural,
yes,
but
no, I remember.
Okay.
I'll just make something up. Yeah, no, I remember. Yeah, so before the show, of course, we were talking about suicide, because as Greg mentioned at the beginning of the show, it is, I guess, International Suicide Prevention Day. And one of the things that I was just highlighting is that suicide, the rates of suicide can be typical across the world, depending on where you are, but they don't usually change too much. One of the things I mentioned is that men almost always complete or commit suicide more, and women attempt more. But one of the things that does differ quite significantly, depending where you are, is the method of suicide. So, for example, when you're looking at some of the Southeast Asian or even Asian island countries, you see a lot more, specifically with women, who actually light themselves on fire as a way to commit suicide. There's also a lot more drownings on some of the island nations, whereby someone will walk out into the ocean, for example, and continue until they're exhausted and are too far to actually swim back, so they essentially drown. These aren't methods of suicide that we see very commonly, certainly in North America, where most suicides are conducted either by firearms hanging or medication overdose, which is also what you frequently see in Europe as well. So sometimes the methods of suicide can vary quite dramatically, but the rates aren't necessarily too different.
Right, interesting stuff. Okay, well, listen, thanks, everyone. Unless there's anything else, is there anything that we haven't talked about that we want to cover? But if there isn't, we'll call it a night.
I wanted to add. Go on.
Oh, no. I was going to say I have one more question. I just was tweeted a question by Sarah Nasra, wondering about the role of loneliness in mental health today. Since we're towards the end of this show, we may not be able to address that, but it's definitely something to look into in the future, unless, Greg, you have some feedback.
We can talk a little bit about it. I mean, I think, loneliness, loneliness will definitely feed in to the problem of if a person has depression, for example, and they are lonely. That loneliness is going to feed into the fact that it's going to be a contributing factor. And then you've got this perpetuating cycle, whereas the fact that they have depression or they have some kind of mental illness might dispose them to being more isolated and not engaging with society and maybe not going to work, etc., and worsen the loneliness. And so I imagine something like loneliness, there could be this self-perpetuating kind of contribution, this sort of almost race to the bottom, I think that is important. And I think a lot of mental health clinics have facilities that have things called day hospitals, where people that have mental illness can come to the day hospital not necessarily for treatment. They're not there for their drugs. They've got maybe a monthly or 3 monthly appointment to see the psychiatrist for that. But they come to the day hospital just in order to connect with people and to feel part of a community. And I think that I think it's really important therapeutically, and I think it's a great question. I don't think that there's a very easy answer to it. I don't think that, but I think it's an important issue, and I think it's that sort of thinking. It's that kind of like trying to empathize and understand what it is that people with mental health are going through that will lead us to kind of coming up with better ways of addressing the problems.
Mm-hmm. I can also say with loneliness, one of the things that we've seen here is certainly loneliness in the elderly isolated population. So this is typically older people who perhaps a spouse has passed away, their family is busy and what have you. And we see quite a bit more depression in older people here. And I know that a lot of sort of community health centers, not unlike what Greg said, have developed social recreation programs. So they're not mental health specific. It's just a place for older people to just come together and whether they play cards or do just recreational things to sort of combat that loneliness, which can certainly trigger feelings of depression, if not depression, because we have to be careful when we're talking about diagnosis, because there's depression, a clinical diagnosis, and then there's feelings of sadness, which may not be depression. So sometimes things like isolation and loneliness can trigger feelings of depression, but not necessarily a clinical diagnosis. Just sometimes we use the word a bit fluidly.
Right. And that's not to take away at all from a person that's down and depressed, but not necessarily diagnosed with clinical depression. I mean, that person may well be suffering. And there are times in life when, and people go through grieving processes if they've lost a loved one, and, we don't at all take away from the extent to which that person is suffering. I mean, that is, we should empathize with them. Okay, any other questions, thoughts, comments, anything out there? Nothing? In that case, we'll call it a night. Thanks, everyone. The guys on the panel, just stay here, and I'll just push stop broadcast.